In a single year, Parkland Hospital's emergency department sees more than 235,000 patients walk, wheel, or rush through its doors. That's more than 600 people every single day, a river of human need flowing through one building in Dallas, Texas. Yet beneath this apparent chaos lies something unexpected: rhythm. The experienced ER nurse learns to find the pattern in the pandemonium, the predictable cycles of shift changes and patient flows, the repetitive tasks performed thousands of times until they become almost meditative. In the controlled urgency of emergency medicine, there exists a strange kind of calm, the focus that comes from knowing exactly what needs to happen next. Welcome to Yawnworthy Jobs for Sleep, where tonight we're following an ER nurse through a single shift at one of America's busiest hospitals. But we're doing something different this time, weaving between 2025 and 1973. Between the modern emergency department with its electronic records and smartphone complications, and the same hospital 52 years earlier, when paper charts and rotary phones were cutting edge technology. Through this dual lens, we'll see how everything has changed and nothing has changed, how nursing persists as an act of presence and competence regardless of the tools available. So settle in comfortably, perhaps adjusting your pillow, letting your breathing slow. Let the rhythm of the hospital's eternal work guide you gently toward rest. October 17th, 2025. The alarm sounds at 4:45 a.m., the same time it has sounded for 26 years of nursing shifts. The nurse, her name is Sarah, though patients usually just see the badge and scrubs, silences it immediately, the motion automatic, and lies still for 30 seconds. A brief meditation before the day truly begins. Outside the bedroom window, Dallas is still dark, the street lights creating pools of orange glow, the city not yet fully awake, but stirring, preparing for another day. The morning routine happens in practice sequence. Shower hot enough to wake fully, coffee strong enough to register, oatmeal eaten while reviewing the news on a tablet. The drive to Parkland takes 22 minutes at this hour, traffic still light. The highways nearly empty compared to the gridlock that will develop within 2 hours. Sarah has driven this route so many times that the turns happen automatically, muscle memory guiding the car while her mind prepares for the shift ahead, mentally reviewing protocols, running through the checklist of things that need checking before patients start arriving in earnest. Parkland Memorial Hospital rises against the dawn sky, a massive complex that has grown and evolved since its founding in 1894. The original building is long gone, replaced by the current structure that opened in 2015, a gleaming facility with state-of-the-art everything, though already showing the wear that comes from running at capacity constantly. Sarah parks in the employee lot, uses her badge to access the staff entrance, and rides the elevator to the second floor where the ER locker rooms are located, greeting the scatter of other early arrivals with nods and tired smiles. The locker room smells like industrial detergent and the faint ghost of yesterday's coffee. Sarah changes into navy blue scrubs, Parkland's ER color, and comfortable shoes that will log approximately 12,000 steps before the shift ends. The ritual includes checking pockets, pen light, good pen, backup pen, small notepad, alcohol wipes, trauma shears. Phone goes into the locker. Personal life stays there too, a conscious compartmentalization that allows full focus on the work ahead. On the wall above the lockers, someone has taped a sign. Deep breath. You've got this. It's been there for 3 years. The edge is curling now. But the message remains relevant. In the staff break room, Sarah pours coffee from the industrial pot that brews continuously, 24 hours a day, and takes a moment to look at the old clock on the wall. It's a simple, institutional clock, the kind with a white face and black numbers, hands that sweep with audible clicks. The maintenance tag on the back shows it was installed in 1973, and somehow it's still here, still keeping time, still ticking through its endless rotations, while everything else in the hospital has been upgraded, replaced, modernized. There's something comforting about its persistence. October 15th, 1973. The same clock, newly installed, hung on a different wall in a different building. The nurse then, her name was Margaret, would have looked at the same white face, the same black numbers, preparing for her shift in much the same way. Early arrival, strong coffee, the mental preparation that nursing has always required. But her scrubs were white, starched stiff, and her cap was still required, the traditional symbol of nursing that would gradually disappear over the next decades. The locker room conversations would have been different. Talk of Vietnam, Watergate, the oil crisis, but the underlying current the same, the anticipation of what the shift might bring, the readiness to meet whatever walked through the doors. The shift briefing happens at 6:45 a.m. in the conference room adjacent to the ER. The night shift nurses are ready to hand over, their exhaustion visible in slouched shoulders and the particular glazed look that comes from 12 hours of fluorescent lighting and constant alertness. The charge nurse, Marcus, pulls up the patient board on the large screen at the front of the room, a digital display showing every bed, every patient, color-coded by acuity and wait time. 12 patients currently in the department, mix of severities: chest pain in Bay 3, pediatric fever in Room 7, psychiatric hold in the quiet room, post-COVID complications in Bay 5. Sarah's assignment includes 6 rooms in the main ER, plus she'll be the backup for trauma activations. The handoff for each patient happens quickly, efficiently. 72-year-old male, chest pain times 2 hours, EKG shows normal sinus rhythm, troponins pending, cardiology consulted via the EMR. 8-year-old with fever to 103. Parent reports 3 days of symptoms, rapid strep negative, waiting on COVID and flu PCR results. The litany continues, each patient reduced to essential facts for the transition, though Sarah knows that once she walks into those rooms, each will expand into a full human being with stories, fears, families, complications that don't fit neatly into handoff reports. The night nurse mentions that the EMR system, the electronic medical record that governs everything now, had a brief outage around 3 a.m., about 20 minutes, where nothing could be documented, orders couldn't be placed, results couldn't be viewed. Everyone just waited. The work paused, a reminder of how dependent the modern hospital has become on systems that are ultimately just computers that sometimes crash. When it came back up, there was the usual scramble to catch up on documentation, everyone charting frantically to record what had happened during the dark period. 1973. No EMR to crash. No system outages to halt work. Everything on paper. Charts thick with handwritten notes. Orders written in pen and carried by hand to the pharmacy or lab. Results called back via telephone and transcribed onto forms. The pneumatic tube system, installed in the 1960s, represented cutting-edge technology. Place the lab specimen in the cylinder, insert it in the tube, and whoosh! Air pressure shoots it through pipes to the laboratory. It seemed like science fiction at the time, this pneumatic mail system, though it was actually technology borrowed from department stores. Margaret would have filled out lab slips by hand, tucked them in with the blood tubes, sent them flying through the tubes, then waited 30 minutes an hour for someone to call back with results. By 7:30 a.m., the day shift has fully taken over, and the ER is beginning its morning acceleration. Sarah starts her rounds, visiting each assigned patient to introduce herself, do initial assessments, verify medication orders. First stop is Bay 3, the chest pain patient. Robert, 72, sitting up in the bed with monitoring leads attached to his chest, the green line of his heart rhythm tracing steadily across the screen above the bed. He looks worried but not acutely distressed, the characteristic expression of someone who knows something might be wrong but isn't sure how scared to be. "Good morning, Mr. Chen. I'm Sarah. I'll be your nurse this morning. How's the pain now?" "Better than it was. Maybe a 5 out of 10. It's here." He touches his chest, center left, the classic location. "And my doctor, well, my telehealth doctor. They said it was probably just indigestion, but it didn't get better with the antacids, so my wife made me come in." This is increasingly common. Patients trying telehealth first, sometimes getting reassurance when they need evaluation, sometimes getting worried when they don't need to be. The technology expands access, but can't replace hands-on assessment, can't feel the quality of the pain, can't pick up the subtle signs that experienced nurses and doctors read instinctively. Sarah does a focused cardiac assessment, listening to heart sounds, checking pulses, asking detailed questions about the pain's onset, character, radiation. The monitoring shows normal sinus rhythm, but that doesn't rule out a cardiac event. EKGs can be normal during early heart attacks, which is why the blood tests matter, checking for enzymes released when heart muscle is damaged. We're going to keep monitoring you and waiting for those blood test results. The good news is that your heart rhythm looks steady and your vital signs are stable. Try to rest and let me know immediately if the pain gets worse or you feel short of breath. The morning continues in this pattern, room to room, patient to patient, each requiring a different kind of attention. The pediatric patient in room 7 is a little girl named Amara, 8 years old, lying on the bed looking small and miserable while her mother sits beside her, hand on her daughter's arm. Fever for 3 days, now lethargic, not drinking much, concerning enough to warrant the ER visit, but probably a virus, something that will resolve with time and supportive care. Sarah checks the IV that the night nurse started, confirms the fluid is running at the right rate, takes fresh vital signs. The tests we ran came back. No strep throat, and the COVID and flu tests are negative. That's good news. It's likely a regular virus, which means it just needs time to run its course. The intravenous fluids will help her feel better, and we can give medicine for the fever. The mother looks relieved, but still worried. The particular expression of parents in ERS everywhere. People for whom just a virus still means their child is sick and suffering. Sarah spends extra time explaining what to watch for, when to worry, how to manage symptoms at home. This teaching is as much a part of nursing as starting IVs or giving medications, helping people understand what's happening. what to expect, when to seek help again. Bay 5 holds a 47-year-old woman, Jessica, with post-COVID complications. She had COVID-19 about 2 months ago, recovered from the acute illness, but has been dealing with persistent fatigue, shortness of breath, brain fog, the constellation of symptoms that's become known as long COVID. Today she came in because the shortness of breath got worse, scary enough that she thought she might be having a heart attack. The workup so far shows nothing acute, chest x-ray clear, cardiac enzymes normal. But she's not imagining her symptoms. This is the challenging middle ground of modern medicine. Real suffering without obvious pathology on standard tests. Sarah checks her oxygen saturation, 97%, perfectly normal, and listens to her lungs, which sound clear. They talk about her symptoms, the frustration of feeling dismissed by doctors who can't find anything wrong, the anxiety that comes from not knowing what's causing the problem or when it will improve. Sarah can offer sympathy, reassurance that she's being taken seriously, explanation that post-viral syndromes are real even when tests are normal. But there's no quick fix, no simple treatment, just a slow process of recovery and the hope that symptoms will gradually improve with time. 1973. Post-viral syndromes existed then too, though they had different names and different causes. Margaret would have seen patients recovering from influenza, from infectious mononucleosis, from any number of viral illnesses that left people weak and tired for weeks or months afterward. The difference was in how they were discussed, understood, treated. Without the internet, without patient advocacy groups and social media sharing, each person experiencing prolonged symptoms might have thought they were alone, might have been more easily dismissed. The medical establishment was even less equipped to handle symptoms without clear diagnostic markers. At least now there's recognition, research, the beginning of understanding, though still not enough answers for people like Jessica, still suffering months after the acute illness resolved. By 9 a.m., the ER has shifted from early morning to full operation. The waiting room is filling up. People who woke with problems serious enough to seek help, parents with sick children now that school hours have started, elderly patients whose issues developed overnight. The board shows 18 patients now, 6 more than at shift start, and the pace accelerates accordingly. Sarah moves between rooms with practiced efficiency, starting intravenous fluids, administering medications, documenting in the electronic medical record, responding to call lights, answering questions, reassuring, explaining, observing for changes that might signal improvement or deterioration. The old clock on the break room wall ticks steadily through all of it, marking time the way it has for 52 years, indifferent to the technology changes and protocol updates and pandemic adaptations. Its hands sweep around the face in the same rotation they made in 1973, in 1985, in 2001, in 2025, the constancy of time passing, while everything else transforms around it. The trauma alert comes at 9:47 a.m., announced by the overhead page system. Trauma activation, ETA 5 minutes. Motorcycle versus vehicle, 32-year-old male, GCS 14, vitals stable. The announcement triggers immediate coordinated movement. The trauma team assembling in Bay 1, the specially equipped room reserved for the most serious cases. Sarah, designated as backup trauma nurse for the shift, joins the team. Trauma surgeon, emergency physician, respiratory therapist, Radiology tech wheeling the portable X-ray machine into position, plus the primary trauma nurse who will lead the hands-on care. The 5 minutes pass quickly, spent preparing, checking equipment, pulling medications that might be needed, ensuring the trauma bay has everything required for resuscitation if this goes badly. Then the ambulance bay doors burst open and the paramedics rush in with the patient on their stretcher, giving rapid-fire report while they transfer him to the ER bed. This is James, 32. Motorcycle struck by a car turning left. Ejected from the bike, landed on his left side, was wearing a helmet, briefly unresponsive at the scene, but talking now, complaining of left arm and left leg pain. Vitals have been stable throughout transport. The patient, James, looks scared and in pain but alert, which is good. He's young, previously healthy, and his body will tolerate trauma better than an elderly or chronically ill person's would. But motorcycle accidents are notorious for causing multiple injuries, often serious ones, so the workup will be thorough. The trauma surgeon takes the lead, conducting the primary survey, while the team works around him. Sarah cutting away clothing to expose injuries, the respiratory therapist monitoring airway and breathing, the other nurse starting a second IV line. Trauma patients need two in case rapid fluid resuscitation becomes necessary. Can you tell me your name? Do you know where you are? What happened? James answers appropriately. Good, no major head injury, but winces with each breath, suggesting rib fractures. His left arm is clearly deformed mid-forearm, broken, and he can't move his left leg without severe pain. The examination proceeds systematically. Airway, breathing, circulation, disability, exposure, the ABCDES of trauma assessment, the protocol that ensures nothing gets missed in the chaos of a critical patient. Orders flow quickly. Portable chest X-ray, pelvis, left arm, left leg, type and screen, CBC, CMP, coags, morphine 4 milligrams IV for pain. Sarah draws the blood, labels the tubes, sends them via the pneumatic tube system. Yes, that 1960s technology is still in use, still the fastest way to get specimens to the lab. While waiting for X-ray results, she focuses on pain management, starting the morphine carefully, monitoring for the respiratory depression that can occur with opioids. James's pain eases from the 10 out of 10, worst of my life, down to maybe a 6. Enough relief that his breathing deepens. His body begins to relax slightly from the rigid tension of severe pain. 1973. A similar trauma, a young man on a motorcycle struck by a car. But the differences would have been stark. No CT scanner in the ER. If head imaging was needed, the patient would have to go upstairs to radiology for the primitive CT scanners just being introduced. Or more likely, just get skull X-rays that showed fractures, but nothing about the brain itself. No protocols standardized across hospitals. Trauma care varied dramatically based on who was working and what they'd learned. Morphine for pain, yes, but fewer options for careful titration, less understanding of proper pain management. The room would have been different too, more crowded probably, with people whose roles were less clearly defined. Everyone rushing but with less coordination. Margaret would have been there doing the same essential nursing work, but with different tools, different knowledge, different expectations. The patient's chances of survival would have been lower. Trauma care has advanced dramatically since the 1970s, and many people who die then would survive now. The X-rays come back quickly, displayed on the large screen in the trauma bay. Chest shows 3 rib fractures on the left side, but no pneumothorax, collapsed lung. Pelvis is intact. Left radius and ulna. Forearm bones both fractured. Left femur, thigh bone fractured. Serious injuries but manageable. He'll need surgery on both the arm and leg, probably pins and plates to stabilize the fractures, then months of recovery. But he'll recover, will likely regain full function, will eventually ride a motorcycle again if he chooses, though his family will probably have strong opinions about that choice. The orthopedic surgeon is consulted via the EMR, a message sent through the electronic system, much faster than the old method of having someone track down the surgeon via pager and phone. Within 20 minutes, the orthopedic resident appears in the trauma bay, examines James, reviews the images, and confirms the plan. Admit to the orthopedic service. Surgery scheduled for this afternoon. Sarah coordinates the transfer, ensuring all documentation is complete, all orders properly entered, pain controlled, family notified. James's wife is in the waiting room, scared and crying, needing reassurance that he's going to be okay. By the time James is admitted and transferred upstairs, it's nearly 11 a.m., and Sarah has been away from her primary assignment for over an hour. She returns to find that her patients have been covered by other nurses but now need attention. Medications due, assessments overdue, families with questions. The ER has filled further. 23 patients on the board now. 4 waiting for admission to the hospital, but no beds available yet, stuck in the ER until space opens upstairs. Room 9 holds a new patient, arrived while Sarah was in the trauma bay. 68-year-old man named David, brought in by his daughter, presenting with confusion. He has a complicated medical history: diabetes, high blood pressure, previous stroke, chronic kidney disease, and takes 12 different medications, a pharmaceutical regimen that his daughter manages by keeping a careful list on her phone. But this morning he was confused, didn't recognize her at first, couldn't remember what day it was, and she panicked and brought him to the ER. Sarah reviews the medications on the daughter's phone, cross-referencing with what's in the EMR. Sometimes there are discrepancies, prescriptions filled but not taken, over-the-counter medications not mentioned to doctors, supplements that can interact with prescriptions. This process of medication reconciliation is crucial but time-consuming, requiring careful attention to get right. David's confusion could be caused by many things: infection, medication side effect, stroke, metabolic derangement from his kidney disease. The workup will need to cast a wide net. Has he been sick recently? Any fever, cough, urinary symptoms? The daughter thinks for a moment. He mentioned that urinating has been uncomfortable. I thought maybe he just needed to drink more water. A urinary tract infection in an elderly person can present as confusion, the body's response to infection affecting the brain before causing obvious urinary symptoms. It's a common scenario in the ER, one that Sarah has seen hundreds of times. The treatment is straightforward if that's the diagnosis: antibiotics, fluids, time. But first, they need to confirm it with tests: urinalysis, urine culture, blood work to check kidney function and rule out other causes. Starting an IV on David proves challenging. His veins are fragile from age and chronic illness, rolling away from the needle, collapsing when accessed. Sarah tries twice without success, then calls for the ultrasound machine, using the technology that allows visualization of deeper veins not visible or palpable on the surface. With ultrasound guidance, She successfully places an IV in a vein in his upper arm, securing it carefully. This needs to last. Needs to deliver the fluids and antibiotics he'll require. 1973. No ultrasound for IV placement. No way to see beneath the skin. A patient with difficult veins meant multiple needle sticks, trying different locations, sometimes giving up and placing a central line, a larger IV threaded into the big veins near the heart, a more invasive procedure, but sometimes the only option. Margaret would have been skilled at finding veins by feel, developing the tactile sensitivity that came from years of experience and no technological assistance. Some nurses became legendary for their ability to start IVs on impossible patients, their skills honed through pure practice. The tools were simpler too, steel needles rather than modern plastic catheters, larger gauges that were more traumatic, less understanding of infection control, so IVs were sometimes left in place for days rather than being changed regularly. The morning rush continues, a stream of patients needing attention, each presenting unique challenges. Room 11 has a teenager, 16-year-old Maya, brought in by her parents for chest pain and difficulty breathing. The initial workup shows nothing obviously wrong. Lungs clear, heart rhythm normal, oxygen saturation 100%. But Maya is clearly in distress, breathing rapidly, hands tingling from hyperventilation. This pattern has become increasingly common, especially post-pandemic. Anxiety manifesting as physical symptoms, sometimes indistinguishable from cardiac or respiratory problems without proper evaluation. Sarah sits down beside the bed, actually sits, taking time despite the pressing demands of other patients, and talks with Maya and her parents. The chest pain started at school during a presentation. The breathing difficulty made it worse, and then she felt like she was dying, was having a heart attack. Couldn't get enough air. Classic panic attack, triggered by performance anxiety, amplified by fear of the symptoms themselves, creating a feedback loop. But knowing it's anxiety doesn't make the symptoms less real or frightening. What you're experiencing is very real, and it's very scary. The good news is that your heart and lungs are working perfectly. We've checked thoroughly. Sometimes our bodies react to stress in ways that feel medical, but are actually our nervous system's fight or flight response getting activated at the wrong time. Has this happened before? Maya nods, looking miserable. A few times. It's been worse since COVID. I used to love presentations, and now I just panic. This is another post-pandemic pattern, increased anxiety, especially in teenagers whose formative years were disrupted by isolation, remote learning, constant health vigilance. The ER can rule out medical emergencies, but can't solve the underlying anxiety that requires therapy, possibly medication, time to heal from the collective trauma of the pandemic years. Sarah provides reassurance, explains breathing techniques that can help abort panic attacks, connects the family with resources for mental health follow-up. The ER's role is stabilization and redirection to appropriate care, not solving chronic problems, though sometimes the distinction feels arbitrary when people are suffering now and need help now. By noon, Sarah has been on her feet for over 5 hours, moving constantly between rooms, and realizes she hasn't eaten or drunk anything since the coffee at 6 a.m. The human body can sustain this for a while. Nurses regularly skip meals during busy shifts, but eventually the lack of food and hydration starts affecting performance, slower thinking, decreased coordination, irritability. She takes 10 minutes in the break room, microwaving leftover pasta from yesterday's dinner, eating quickly while checking her phone, 3 texts from her daughter about something at school, a reminder about a dentist appointment next week, the usual life accumulation that continues, whether you're at work or not. The old clock on the wall shows 12:17 p.m. Its hands have made 6 complete rotations since the shift started, marking 360 minutes of work, of patients cared for, of medical decisions made and executed. The clock witnessed all of it with mechanical indifference, ticking steadily through trauma activations and medication administration and difficult conversations, keeping time the way it has for 52 years, the way it will for however many years remain until some future renovation finally removes it, replaces it with something digital that displays time without the audible tick, without the sweeping second hand, without the tangible passage of each moment. 1973. Noon meant the main cafeteria rush. Nurses taking their breaks in shifts, eating hot meals prepared on site before hospital food service was outsourced to contractors. Margaret might have sat in this same break room, though it was in a different building, eating meatloaf and mashed potatoes, drinking coffee from a ceramic mug rather than a disposable cup. The conversations would have been different, discussing recent episodes of popular TV shows since there was no way to watch them later, sharing news from newspapers rather than phones, talking about the upcoming holiday season. But the underlying themes would have been the same: the challenges of the work, difficult patients, frustrating physicians, the struggle to maintain professional standards while dealing with institutional constraints. Nursing has always involved these tensions, these negotiations between ideal care and realistic possibility. The page overhead interrupts the brief respite. Sarah to room 7. Patient request. Break over. Sarah disposes of her empty container, refills her water bottle, and returns to the floor, where the afternoon shift is already building toward the next peak. The ER never truly empties, never reaches a point where all patients are discharged, and the board is clear. There's always someone waiting, always another ambulance en route, always the next crisis beginning while the current one is still resolving. The work flows like a river, continuous and never quite the same twice, despite following the same general course. The afternoon brings a different patient mix. People whose symptoms couldn't wait for regular doctor's appointments or who don't have regular doctors, school-age children released early with illness, workers injured on job sites. The waiting room board now shows a 3-hour wait for non-urgent cases, and the families sitting there look increasingly frustrated, checking phones, asking repeatedly when they'll be called back. The triage nurse explains patiently over and over that patients are seen based on severity, not arrival time, that chest pain goes before sprained ankle, that the wait reflects how busy the ER is, not indifference to their suffering. Sarah's patient assignment has shifted. 2 of her morning patients were admitted and moved upstairs, replaced by new arrivals requiring different kinds of attention. Room 4 now holds an elderly woman named Dorothy, 91 years old, brought from her assisted living facility for altered mental status. The paperwork from the facility is minimal. Resident more confused than baseline, refusing meals, staff concerned. Dorothy sits in the bed looking small and bewildered, wearing the clothes she arrived in because no one brought a change. holding a worn purse in her lap like an anchor to familiarity. Approaching elderly, confused patients requires particular gentleness, awareness that their confusion is often compounded by fear. They don't know where they are, why they're here, who these strangers are. Sarah introduces herself slowly, clearly, kneeling beside the bed to be at Dorothy's eye level rather than looming above her. Hello, Dorothy. I'm Sarah. I'm a nurse. You're at the hospital because your caregivers were worried about you. We're going to help figure out what's wrong so you can feel better. Dorothy looks at her with eyes that show moments of clarity, alternating with fog. Where's my daughter? She was supposed to pick me up. Sarah checks the chart. Dorothy's daughter died 6 years ago, but the confusion sometimes takes her back to earlier times when her daughter was still alive. Let's make sure you're comfortable here first, and then we'll figure out about your daughter. The assessment reveals probable dehydration. Her mucous membranes are dry, skin has poor turgor, vital signs show low blood pressure and elevated heart rate. Elderly people often don't drink enough fluids, and even mild dehydration can cause significant confusion. Blood work will check for infection, electrolyte imbalances, kidney function, but the immediate treatment is straightforward. Intravenous fluids, gentle rehydration, time for her body to recover equilibrium. Sarah starts the IV. Dorothy's veins are difficult but not impossible, and hangs the fluid bag, adjusting the rate to deliver hydration without overwhelming her system. 1973. Elderly patients came to the ER then too, often sicker, often having waited longer to seek care. But the conversation around aging was different. Expectations were different. Dorothy might have been in a nursing home rather than assisted living, might have been more sedated with medications used differently then, thorazine and similar drugs given more freely to control agitation, which was sometimes just confusion or anxiety. Margaret would have provided the same essential care, fluids, assessment, attempting to determine the cause of confusion, but with less emphasis on preserving dignity and autonomy, less understanding that confusion is often reversible rather than inevitable decline. The medical establishment treated the elderly more paternalistically then, making decisions for them rather than with them, though individual nurses often advocated fiercely for their patients' humanity, even when systems didn't support it. Room 8 has a patient Sarah hasn't met yet. 43-year-old man named Carlos, brought by police on a mental health hold. He was found wandering on a highway overpass, apparently contemplating jumping, and when police intervened, he became agitated, threatening but ultimately cooperative enough to come to the hospital voluntarily. Now he sits on the bed in the behavioral health room, a specially designed space with nothing that could be used for self-harm, camera monitoring, furniture bolted to the floor, looking exhausted and defeated. Mental health crises have increased dramatically in the years since the pandemic. The accumulated stress of isolation, economic insecurity, health fears, and social disruption, creating waves of anxiety, depression, and suicidal ideation. The ER serves as the crisis intervention point, stabilizing people enough to connect them with appropriate mental health resources. Though the system is overwhelmed, wait times for psychiatric beds are measured in days, and people often sit in ER rooms for extended periods with essentially nowhere else to go. Sarah introduces herself, maintains calm presence, doesn't treat Carlos like he's dangerous, even though the police report used that word. I understand you've had a really difficult day. I'm here to make sure you're physically okay, And we have a mental health crisis counselor who will be coming to talk with you about what you're experiencing and what help is available. Carlos doesn't make eye contact, speaks quietly. I just, I can't do this anymore. Everything is too much. I lost my job. My wife left. I can't afford my apartment. What's the point? There are no easy answers, no quick fixes for the accumulation of losses and stresses that have brought Carlos to this point. Sarah can offer immediate safety, assessment for medical issues that might be contributing. Depression can have physical causes, thyroid problems, vitamin deficiencies, chronic pain, and connection to resources. But the systemic issues, lack of affordable housing, gaps in mental health services, economic precarity, those are beyond what an ER nurse can address, though they're present in the room nonetheless, invisible forces shaping the crisis as much as any internal neurochemical imbalance. The crisis counselor arrives within 30 minutes. This is relatively quick, a function of this being Parkland, a major urban hospital with better resources than smaller facilities. Together, Sarah and the counselor assess Carlos's immediate risk, his support system, minimal, his willingness to accept help, ambivalent but not refusing. The decision is made to admit him to the psychiatric unit for further assessment and stabilization. Not a long-term solution, but at least immediate safety, a pause in the crisis, time to develop a plan for next steps. 1973. Mental health treatment was dramatically different 52 years ago. Carlos might have been committed to a state psychiatric hospital for months, treated with medications and approaches that are now considered outdated or even harmful. Or he might have been simply released after a brief hold, told to pull himself together, provided with minimal follow-up resources. The recognition that mental health is health, that crisis intervention should be trauma-informed and dignity-preserving, that suicide prevention requires addressing social determinants and not just individual pathology. These are relatively recent developments. Margaret would have cared for patients in mental health crisis, but the system she worked within was more coercive, less focused on patient autonomy, though sometimes, paradoxically, provided more intensive long-term treatment through state hospital systems that have since been largely dismantled. The afternoon progresses with continued intensity. Pediatric ear infection, adult with diabetic complications, elderly patient with medication side effects, construction worker with a nail gun injury to his hand, painful and bloody but ultimately repairable, woman with symptoms suggesting kidney stones, pain so severe she's vomiting, requiring IV pain medication and imaging. Each patient requires focused attention, assessment, intervention, documentation, the cycle repeating with variations, but fundamentally the same pattern of nursing work performed thousands of times throughout the shift, throughout the year, throughout a career. Around 3 p.m., the old clock in the break room chimes softly, a feature Sarah had forgotten it had, since she's rarely in the break room at the precise hour to hear it. The chime is melodic, gentle, oddly anachronistic in the modern ER with its digital monitors and electronic alerts. But there it is, marking the hour the way it has since 1973, a small assertion of continuity in a world of constant change. Room 12 presents a challenge of a different sort. Young mother, 24 years old, brought by her partner for symptoms that seem vague and shifting. Sometimes chest pain, sometimes dizziness, sometimes trouble breathing. Her 6-month-old baby is with her, secured in a car seat on the floor beside the bed. As Sarah conducts the assessment, a different picture emerges. The patient, Amanda, is exhausted, overwhelmed, showing signs of postpartum depression and anxiety that she hasn't disclosed to her doctor because she's afraid of being judged, afraid of being labeled a bad mother. The chest pain. Is it possible it's panic, like your heart races and you feel like something terrible is about to happen? Amanda's eyes fill with tears. Yes, exactly like that. I thought I was dying. I thought I was having a heart attack and my baby would be left without a mother and it would be my fault. The medical workup proceeds to rule out physical causes, but Sarah knows the real issue is mental health. Postpartum depression affects up to 1 in 7 women, more in the post-pandemic era, and often goes unrecognized or untreated. The ER can provide crisis intervention, referrals to postpartum support services, sometimes medication initiation. But what Amanda really needs is ongoing support, therapy, possibly medication, help with child care to reduce overwhelming stress. The social worker is consulted, resources provided, follow-up arranged, and Sarah spends extra time just listening, validating that what Amanda is experiencing is real and treatable, that asking for help is strength, not weakness. The baby wakes during the conversation and begins to fuss. Amanda immediately tenses, reaching for the car seat with movements that suggest this is one more demand she's not sure she can meet. Sarah asks, "Would you like me to hold her while we finish talking?" Sometimes it's easier to focus on yourself when someone else has the baby for a minute. The relief on Amanda's face is immediate. Sarah lifts the baby, tiny, warm, smelling of milk and baby soap, and holds her comfortably, decades of nursing having made her comfortable with infants. The baby settles against her shoulder, and Amanda visibly relaxes, able to talk more freely without the immediate pressure of infant care. They discuss medications compatible with breastfeeding, therapy options, the importance of asking for help from family and friends, how to recognize when symptoms are worsening. 1973. Postpartum depression existed then, of course. It has always existed. But it was even less discussed, less recognized, more stigmatized. Women were expected to handle motherhood with grace and gratitude, and admitting to struggling was seen as personal failure rather than a medical condition. Margaret would have seen women like Amanda, though they might not have come to the ER for these symptoms, might have suffered silently until the depression became more severe or manifested in ways that couldn't be ignored. The treatment options were more limited too. Therapy was less accessible. Medications were cruder with more side effects. Support systems were more informal and dependent on family structures that were already changing. At least now there's recognition, research, advocacy, though still not enough resources to meet the need. By 4 p.m., Sarah has been working for 9 hours, most of it without sitting down, and the fatigue is accumulating in her legs, her back, her shoulders. The ER has reached that late afternoon density where almost every bed is full. The waiting room is packed, and the sense of barely controlled chaos pervades the department. The charge nurse is juggling assignments, trying to distribute the workload equitably while ensuring high acuity patients get adequate attention. 3 patients are boarding, waiting for hospital admission, but no beds available yet, which means they remain in the ER, occupying space and requiring ongoing nursing care despite technically being admitted to other services. Room 6 has a situation developing. Elderly man with chest pain, similar presentation to the morning's patient, but this one is progressing differently. His EKG shows changes consistent with a heart attack in progress. ST elevation, the characteristic pattern that indicates complete blockage of a coronary artery, heart muscle dying from lack of oxygen. This is a STEMI, ST elevation myocardial infarction, requiring immediate intervention to open the blocked artery and restore blood flow. The protocol activates automatically. Cardiology called for emergency catheterization. Medications administered to prevent blood clotting. The patient moved to the cardiac catheterization lab within the hospital where specialists will thread a catheter through his blood vessels to the heart, inflate a balloon to open the blockage, place a stent to keep the artery open. The door to balloon time, the interval between arriving at the hospital and getting the artery opened, is a quality metric that hospitals track obsessively because every minute of delay means more heart muscle death, worse outcomes, higher mortality. Sarah moves quickly but calmly, administering medications, starting a second IV line, coordinating with the cath lab team, explaining to the terrified patient and his wife what's happening, what will happen next, maintaining the professional composure that helps keep frightened people from panicking. The patient is moved out of the ER within 23 minutes of the STEMI being identified, well within the guidelines, and Sarah returns to her other patients, the adrenaline spike from the emergency slowly settling back to baseline. The remainder of the afternoon blends. Together, medication administration, wound care for the construction worker whose hand has been sutured and dressed, discharge instructions for patients being sent home, admission coordination for those being kept, phone calls with specialists and consultants, documentation in the EMR that seems to accumulate faster than she can complete it. The electronic record is supposed to improve efficiency, but sometimes it feels like the opposite. Clicking through screens, navigating menus, entering the same information in multiple places to satisfy different requirements. Room 9, David the confused man, has been in the ER since mid-morning, and his lab results have finally come back confirming what Sarah suspected. Urinary tract infection with kidney involvement. Elevated creatinine indicating his kidney function has worsened. Blood cultures pending to see if the infection has spread to his bloodstream. He's been started on intravenous antibiotics and is already showing some improvement, less confused, more oriented, recognizing his daughter consistently now. He'll be admitted to the medicine service. Likely will need several days of IV antibiotics and careful monitoring of his kidney function, but should recover fully. His daughter, who has been waiting patiently all day, asks Sarah about preventing this in the future. He keeps getting these infections. Is there something we should be doing differently? Sarah sits down to explain. Actually sits despite the pressing demands, because this teaching matters, because preventing the next ER visit is as important as treating this one. They discuss hydration, hygiene, signs to watch for, when to call the doctor before symptoms become severe. The daughter takes notes on her phone, asks thoughtful questions, clearly wants to provide good care for her father. This is the part of nursing that doesn't show up in metrics or quality scores, but matters enormously. The education, the empowerment, the provision of knowledge that lets people manage health at home. 1973. The same conversation might have happened, though without the phone for note-taking, perhaps written on paper provided by the hospital. But the daughter's role might have been less expected. In that era, elderly parents were more likely to live with adult children or in nursing homes, less likely to be managing complex medical care independently in the community. The medications would have been simpler or non-existent. Many of David's 12 medications didn't exist in 1973. The care coordination less complex. Margaret would have provided the same kind of teaching, but the context was different. Expectations were different. The healthcare system operated on different assumptions about family structure and caregiving responsibilities. By 5 p.m., the day shift is beginning to wind down, preparing for the evening shift transition. Sarah starts organizing her documentation, ensuring everything is charted, all orders are completed, preparing the handoff report for the nurse, who will take over her patients. The old clock shows 5:03, its hands sweeping steadily through another hour, another rotation, time passing whether anyone pays attention or not. The ER continues its perpetual motion around the clock, patients coming and going, crises emerging and resolving, the work flowing forward regardless of who is doing it or when. The evening shift nurse who takes over Sarah's assignment is Michael, a younger nurse with 3 years of ER experience, competent and still enthusiastic in ways that veterans sometimes aren't. Sarah provides detailed handoff on each patient, current status, pending tests, what to watch for, family dynamics, social issues that might affect discharge planning. This transfer of information is critical. Gaps in handoff communication are where errors occur, where important details get lost, where patients fall through cracks in the system. But Sarah isn't leaving yet. She's picked up extra hours to cover a staffing shortage. The ER is chronically understaffed, a problem that has worsened since the pandemic when many nurses left the profession, burned out from the intensity of COVID care, the moral injury of inadequate resources, the trauma of watching so many people die. Those who remain often work extra shifts to fill the gaps, the overtime both financially necessary and physically exhausting. A temporary solution to a systemic problem that shows no signs of improving. Her assignment for the evening is different. She'll float between rooms as needed, helping wherever the load is heaviest, responding to emergencies, providing backup for the primary nurses. This flexibility requires broad competence and adaptability. Being able to walk into any situation and quickly assess what's needed, what's most urgent, how to help. The evening hours bring a different patient mix again. People leaving work now developing symptoms or acknowledging symptoms they ignored all day. Children home from school whose parents finally have time to bring them in. The beginning of the night shift's characteristic emergencies, alcohol and drug-related issues, psychiatric crises, injuries from evening activities. The waiting room remains full, the boards show no signs of clearing, and the sense is that the ER is simply holding steady, maintaining equilibrium rather than gaining ground. Room 14 has a young man, 23, brought by friends for drug overdose, specifically fentanyl, the synthetic opioid that has caused overdose deaths to skyrocket in recent years. He was found unresponsive, was given Narcan, naloxone, by his friends who carried it for exactly this possibility, regained consciousness, and was brought to the emergency room for evaluation. Now he sits on the bed looking sullen and defensive, clearly wanting to leave, resistant to the suggestion that he needs help for substance use disorder. Sarah takes the vital signs. Heart rate elevated, blood pressure slightly high, pupils constricted despite the Narcan, and attempts to engage him in conversation about what happened, what help is available, whether he's interested in treatment. This is challenging work, meeting people at their most vulnerable and resistant, offering help that often gets refused, knowing that the next overdose might be fatal. The nationwide epidemic of opioid addiction has filled ERs with these encounters. Young people whose substance use escalated from prescription pain medications or recreational experimentation into full addiction, the powerful synthetic opioids making overdose increasingly likely. I'm fine. I just want to go home. His tone is flat, eyes not meeting hers. I understand you feel fine now, but fentanyl is still in your system, and there's a risk you could stop breathing again after you leave. We'd like to keep you for observation for a few hours. Make sure you're safe. And we have people who can talk with you about treatment options if you're interested. He's not interested, this is clear. Sarah can't force him to stay. Patients have the right to refuse treatment and leave against medical advice. But she's required to ensure he understands the risks, signs the appropriate forms, has information about resources if he changes his mind. She provides him with information about addiction treatment programs, naloxone distribution sites, harm reduction services, knowing the paper will probably end up in the trash, but hoping some fragment of information might stick, might matter at some future moment when he's ready to seek help. 1973. The drug epidemic then was different. Heroin rather than fentanyl, overdoses still tragic but less instantly lethal, Narcan not yet widely available outside hospitals. Margaret would have seen overdose patients, but the public health response was more punitive, less focused on treatment and harm reduction. Addiction was more stigmatized, treated more as moral failure than medical condition, though individual healthcare providers often tried to help despite systemic barriers. The current emphasis on medication-assisted treatment, on meeting people where they are, on harm reduction strategies that keep people alive until they're ready for recovery. These represent real progress, though the epidemic has worsened despite better understanding of how to address it. Room 16 has a regular, Thomas, a 57-year-old man experiencing homelessness who comes to the ER frequently, usually with minor complaints that are really about having nowhere else to go, needing shelter for a few hours, wanting human contact. Tonight, it's foot pain, and when Sarah examines his feet, the pain is real. Severe blisters, early signs of infection, the result of walking long distances in shoes that don't fit properly. This is treatable, wound care, antibiotics, new shoes from the social work department's donation closet, but it's also a symptom of the larger problem that the ER can't solve. Sarah knows Thomas, has cared for him multiple times over the years, knows his history, veteran PTSD, fell through gaps in VA services, lost housing, has been on the streets for 6 years. He's pleasant, grateful for care, never demanding, apologizes for bothering the staff, even though his medical needs are legitimate. She cleans and dresses his wounds carefully, prescribes antibiotics, arranges for the social worker to provide shoes and socks, connects him with information about shelter beds available tonight. Thanks, Sarah. I appreciate you taking time with this. Of course. Thomas, those wounds need to be kept clean and dry. If you can get to the shelter tonight, that would really help the healing. He nods non-committally. The shelters have rules, restrictions, sometimes feel less safe than the streets. and Thomas has his reasons for avoiding them even when beds are available. Sarah can provide medical care but can't solve the housing crisis, can't fix the inadequate mental health system, can't address the structural issues that create and perpetuate homelessness. 1973. Homelessness looked different then, less visible in some ways, handled more through state institutions that have since been largely eliminated. The veteran population experiencing homelessness was dealing with Vietnam PTSD, just beginning to be recognized as a distinct condition. Margaret might have seen Thomas's father or uncle, younger then, dealing with similar issues in a different era. The services available were different, in some ways more comprehensive, state hospitals, though often problematic, and in some ways no recognition of housing as health care, less emphasis on wraparound services. The ER served a similar function then as now, safety net, provider of last resort, place where people came when they had nowhere else to go. Around 7 p.m., Sarah helps with a pediatric case in room 18, 3-year-old with a fever brought by first-time parents who are terrified their child is seriously ill. The assessment shows a simple viral infection, temperature of 101.5, child alert and playing with toys despite the fever, reassuring signs that this is nothing dangerous. But the parents have been tracking every symptom on apps, consulting Dr. Google, reading about rare diseases, and have worked themselves into significant anxiety. Sarah sits down with them, shows them how to assess their child properly, explains what symptoms would be concerning versus what's normal for a viral illness, demonstrates how to give fever-reducing medication, discusses when to seek medical care versus when to manage at home. This teaching is important, helping parents develop the confidence to care for minor illnesses at home, reducing unnecessary ER visits, empowering them to trust their judgment while knowing when professional help is truly needed. The mother shows Sarah her phone, where she's been tracking the child's temperature every hour, logging symptoms in an app, researching possible diagnoses. I know we're probably being paranoid, but everything online makes it sound so scary. Fever can mean meningitis or sepsis or... Yes, fever can mean those things, but usually it means a virus. Your daughter is alert, playing, drinking fluids. Those are all very reassuring signs. The app tracking is fine, but try not to let it increase your anxiety. Trust what you're seeing, a child who is sick but not severely so. This is a particularly modern parenting challenge. Access to vast medical information online, increasing anxiety rather than reducing it. Every symptom potentially representing the worst-case scenario found in search results. The parents need permission to trust their observations, reassurance that they're capable of caring for their child, guidance on what actually 1973. Parents then had different resources and different anxieties. No internet to consult, no apps to track symptoms, more reliance on family. Knowledge passed down generationally. Pediatrician phone calls rather than Google searches. Margaret would have provided similar reassurance, but about different concerns shaped by that era's context. In some ways, it was easier, less information overload, and in some ways harder, less access to immediate answers when genuinely needed. The evening progresses with steady activity. Chest pain evaluation for a middle-aged woman, ultimately anxiety but requiring full cardiac workup to confirm. Laceration repair for a teenager who cut his hand while cooking. Elderly woman with a fall and possible hip fracture. X-rays pending. Diabetic patient with blood sugar over 500 requiring insulin and admission. Sarah moves between rooms, assisting primary nurses, taking on tasks wherever help is needed. The flexibility of the floating role allowing her to fill gaps in real time. Around 8 p.m., she finally takes another break, reheating soup from the vending machine, eating quickly in the break room while checking her phone. Her daughter has texted multiple times about needing help with math homework. Sarah texts back, apologetic explanations that she's working late. Will help when she gets home. Maybe send a picture of the problem, and she'll look during the next break. The juggling of work and family is perpetual. The guilty awareness that her daughter is home alone handling things that maybe a parent should be present for. The reality that the bills require the overtime, that the ER needs the staff, that choices aren't always really choices. The old clock shows 8:14. Sarah looks at it while eating soup that tastes like salt and tomato-flavored nothing, and wonders about all the nurses who've sat in this room over 52 years, looking at that same clock face, eating hurried meals, checking the time to see how much of their shift remains. Margaret in 1973, younger nurses Sarah has worked with who've since left for other jobs or other careers, travelers passing through on temporary contracts, new graduates just beginning their nursing journeys. The clock has witnessed all of them, tick through all their shifts, mark time with the same steady mechanical persistence. October 15th, 1973, 8:14 p.m. Margaret might have been looking at the newly installed clock, noting its clear face, appreciating that someone finally replaced the old clock that had been running slow for months. She might have been eating a sandwich from home, drinking coffee from a thermos, discussing with colleagues the changes coming to nursing, the shift away from diploma programs toward college degrees, the growing emphasis on nursing as a profession rather than a vocation, the beginning awareness that nurses deserved better pay and working conditions. The specific concerns were different, but the underlying experience was the same. The fatigue of a long shift, the awareness of time passing, the brief rest before returning to patient care, the life of a nurse marked by service to others' immediate needs. By 9 p.m., Sarah is ready to finish. She's been at the hospital for over 15 hours, most of it in motion, and the accumulated fatigue sits heavy in her muscles and bones. She completes her final documentation, ensures all pending tasks are communicated to the night shift, and changes back into street clothes in the locker room. Other nurses are coming in for the night shift, starting their days as Sarah ends hers, the eternal cycle of the hospital continuing regardless of who is working or what time it is. Sarah should leave. She's technically off the clock, has worked enough hours to earn time and a half overtime, and needs to get home to her daughter. But before leaving, she does what she often does, walks through the ER one more time, checking on patients she cared for during the shift, seeing how they're progressing, satisfying the nurse's need to know the story's endings, even though most stories in the ER don't truly end. Just transition to the next chapter. Room 3. Mr. Chen with the chest pain from early morning. Admitted to the cardiac unit, his troponins elevated enough to confirm a minor heart attack. Scheduled for cardiac catheterization tomorrow morning. His wife is with him, holding his hand, both of them scared but grateful that he came in when he did, that the damage was caught early and treated before it became catastrophic. Room 7, Amara, the little girl with fever. Discharged hours ago, fever controlled with medication, sent home with instructions for supportive care, and follow-up with her pediatrician. The bed now holds a different child, a different family, a different concern. Room 9, David with the UTI, admitted to the medicine floor, already significantly less confused on IV antibiotics. His daughter more relaxed now that the cause has been identified and treatment initiated. Dorothy, the 91-year-old with dehydration, is also admitted, waiting for a bed to open on the geriatric floor. She's had a liter of IV fluid and looks brighter, more alert, has eaten some crackers and juice provided by the staff. She still doesn't fully understand where she is, but she's less frightened, less lost in the fog that dehydration and confusion created. Amanda, the young mother with postpartum anxiety, was discharged with prescriptions, referrals, resources, and the kind of validation that sometimes matters as much as medical treatment. Whether she follows through with the mental health referral, whether the medications help, whether she gets the support she needs, these outcomes will remain unknown to Sarah, whose role was crisis intervention and redirection, not long-term care. Thomas, the homeless veteran with infected feet, left against medical advice as expected, took the antibiotics, accepted the shoes and socks, but declined the shelter referral and left to find his usual sleeping spot. He'll be back, probably within a few weeks, with some other minor complaint that's really about needing care and human connection. The ER at 10 p.m. has shifted fully into its night mode, lights dimmed in patient rooms, the general noise level lower, though still punctuated by monitor alarms and overhead pages, fewer visitors wandering the halls. The night shift operates with smaller staff, relying on experience and efficiency to manage the continuing flow of patients that never entirely stops. Midnight to dawn brings its own characteristic emergencies, substance use complications, psychiatric crises, the injuries that happen when judgment is impaired and inhibitions are lowered. Sarah finds herself in the break room one final time, drawn by habit and the need for a moment of quiet before driving home. The old clock shows 10:23. She sits in the worn chair by the window, looking out at the parking lot lights and the Dallas skyline beyond, thinking about the shift, the patience, the work, the weight of it all. 26 years she's been doing this. Started as a new graduate in 1999, nervous and incompetent, gradually becoming skilled through repetition and experience, watching healthcare transform around her, the rise of electronic medical records, the AIDS crisis giving way to new epidemics, 9/11 and its aftermath, the 2008 financial crisis bringing waves of uninsured patients, the incremental expansions and contractions of healthcare access, and then COVID, the pandemic that changed everything and nothing, that revealed the healthcare system's fragility while proving the resilience of the people working within it. 1973. Margaret would have had her own decades of experience by then, would have seen nursing transform from the 1950s through the early 70s, watched the profession professionalize, watched medicine advance, watched society change. She would have cared for polio patients before the vaccine eliminated that disease, would have worked before modern ventilators and ICUS, would have seen antibiotics transform formerly deadly infections into treatable conditions. Every generation of nurses thinks their era is uniquely challenging, and every generation is correct. The challenges change while the fundamental work remains the same. The question Sarah finds herself contemplating, sitting in the quiet break room, with the clock ticking audibly in the background, is what actually matters, not in some abstract philosophical sense, but practically. What makes the difference in patient outcomes, in the quality of care, in whether people get better or worse, live or die? The technology matters, no question. Modern diagnostic tools save lives that would have been lost in 1973. The CT scan that diagnosed the stroke in time for clot-busting drugs. The cardiac catheterization lab that opens blocked arteries before heart muscle dies. The ventilators that support breathing when lungs fail. The electronic medical records that prevent medication errors and track allergies and ensure continuity of care. All of this represents genuine progress, capabilities that didn't exist 52 years ago. But the technology isn't sufficient. Sarah has learned through decades of experience that what often makes the difference is presence. The nurse who notices a subtle change in patient condition before it becomes a crisis, who asks the right question that reveals the actual problem rather than the presenting complaint, who takes time to explain and teach when patients are scared and confused, who advocates for patients when systems threaten to fail them, who provides human connection in moments of fear and pain and vulnerability. This hasn't changed since 1973. Margaret would have provided that same presence with different tools, in a different system, under different constraints. The essence of nursing, observation, assessment, intervention, evaluation, and underlying all of it, care, remains constant across decades and technological revolutions. The challenge is maintaining that presence under conditions that make it increasingly difficult. Understaffing that means too many patients per nurse, documentation requirements that pull attention away from bedside care, productivity metrics that prioritize throughput over quality of interaction, the emotional toll of crisis after crisis without adequate time for processing or recovery. The burnout that has driven so many nurses out of the profession isn't primarily about the work itself. Most nurses are drawn to the work, find meaning in it, value the ability to make a difference in people's lives. The burnout comes from systemic barriers that prevent doing the work properly, from being forced to provide care under conditions that compromise the care, from moral injury that accumulates when you know what patients need but can't provide it due to institutional constraints. 1973, Margaret would have faced different systemic issues, less professional autonomy, more rigid hierarchies, fewer opportunities for advancement, lower pay relative to inflation, but some issues persist across eras. Inadequate staffing, administrative priorities that conflict with patient care, the tension between ideals and reality. The specific manifestations change while the underlying dynamics remain surprisingly consistent. Sarah checks her phone. 10:47 p.m. She should leave, needs to leave, has a teenager at home who probably fell asleep waiting for help with math homework, needs her own sleep before potentially doing this all over again tomorrow. But she sits for a few more minutes, allowing the quiet, watching the clock's second hand sweep through its circuit, marking time with mechanical precision. The old clock from 1973 has witnessed so much. Patients saved and patients lost, medical advances and medical errors, compassionate care and systemic failures, individual heroism and institutional shortcomings. It has ticked through all of it without judgment, without memory, just faithfully marking time's passage, which is perhaps all any of us can do. Keep showing up, keep doing the work, keep providing care to the best of our ability within the constraints we face, trusting that the accumulated small actions of competence and compassion add up to something meaningful even when individual shifts feel insignificant or overwhelming. The ER will continue operating through the night, through tomorrow, through next week and next year, and the next decade, as it has since the hospital opened. Different nurses will work different shifts. Different patients will come seeking help. Different crises will emerge and be resolved or not resolved. And the fundamental work will continue. The eternal human need for healing met by the human capacity to provide care, mediated by whatever technology and systems exist in that particular moment. Sarah stands, stretches, picks up her bag from the locker, and heads toward the exit. Walking through the ER one final time, she passes rooms occupied by people in the midst of their own crises, their own moments of need and fear and hope for healing. The night shift nurses are working steadily, competent and focused, the work flowing forward carried by different hands, but the same underlying commitment. Outside, the October night is cool and clear, a relief after the recycled air of the hospital. Sarah walks to her car, appreciating the silence, the absence of monitor alarms and overhead pages and ringing phones. The drive home takes 20 minutes through sparse traffic. Streets mostly empty at this hour, Dallas settling into its night rhythm of closed businesses and residential quiet. At home, her daughter is asleep on the couch, math textbook open on her lap, pencil still in hand. Sarah carefully removes the book and pencil, covers her daughter with a blanket, and stands for a moment looking at her sleeping face. Young, peaceful, untroubled in this moment by the homework struggles or the absent parent or the thousand small and large challenges of being 16. This is why Sarah does the work ultimately, to provide for this child, to model dedication and competence, to contribute to a healthcare system that, for all its flaws, will be there if her daughter needs it, staffed by nurses like Sarah who show up shift after shift to provide care. The night deepens. Sarah prepares for bed, setting the alarm for 4:45 a.m. because she's working tomorrow too. Another shift, another 12 hours of patient care, another day in the endless cycle of nursing work. At Parkland, the ER continues operating, the night shift handling whatever emerges, the flow of patients seeking help never stopping regardless of the hour. And in the break room, the old clock from 1973 ticks steadily through the night, its hands sweeping around the familiar white face, marking time as it has for 52 years and will continue for however many years remain until some future renovation finally retires it, replaces it with something digital and silent, erasing one small piece of continuity between past and present. But for now, the clock remains. Its tick is audible in the quiet moments between crises. Its hands point to the current time, 11:43 p.m. The night shift nurses hear it when they take brief breaks, the sound mixing with the institutional hum of HVAC systems and distant monitor alarms. The clock witnessed Margaret in 1973, witnesses Sarah in 2025, will witness whatever comes next, faithfully marking time through all the transformations and continuities that define nursing, that define healthcare, that define the human effort to care for one another through sickness and health, through crisis and recovery, through all the moments that make up a life, a shift, a career dedicated to the service of healing. The ER persists. The work continues. The nurses show up shift after shift, doing what nurses have always done, observing, assessing, intervening, caring. The technology changes, the systems change, the specific challenges change, but the fundamental work remains: the provision of skilled, compassionate care to people in their most vulnerable moments, the commitment to showing up even when the work is hard, even when the systems are flawed, even when the outcome is uncertain. This is nursing. The daily choice to care, to help, to heal, made and remade each shift, each patient, each moment when someone needs help, and you have the knowledge and skill and willingness to provide it. Sarah sleeps, preparing for tomorrow's shift. The ER operates through the night. The clock ticks on. Time passes. The work continues. The cycle repeats. And in that repetition, in that eternal rhythm of need met by care, crisis followed by intervention, fear soothed by competent presence, in that rhythm lies the heartbeat of nursing, steady and persistent, marking time through decades and eras and technological revolutions. The human heart of healthcare beating beneath all the machinery and documentation and systemic complexity, still fundamentally about one person helping another person through a moment of suffering, one shift at a time, one patient at a time, one small act of care at a time, accumulating into lives saved, suffering eased, hope restored, the quiet heroism of showing up to do difficult work day after day after day.